Good evening and welcome back, dear friends. So today we are having an interesting topic with a very eminent speaker. Uh, Today we are having Dr. J.V. Peter. You are very familiar with Dr. Peter now. He is the senior most critical care physician in India, and he was former HOD and now the director of medical services in St. John's Villur. And he is a very expert in organophosphorus poisoning. Those who are working in critical care field, especially like interested in toxicology, might have already heard Dr. Peter talking about OP poisoning. uh, I know that in India we have different ways of like treating organophosphorus poisoning. Still, we don't have a proper consensus on that. And regarding the use of like how much atropinization has to be done, whether these oximes are really going to useful or not, then different like Sri Lankan regime and other regimes. So it's always a debating topic, and again, most of the time we go with the personal preferences. So today we have Dr. Peter. He is going to talk from his experience, and obviously mixing with the evidences available. Sir, please, sir.
Thank you, Anup, for giving me this opportunity uh, to share some of my thoughts on a topic that I've been working on personally for about 30 years now. And there were so many questions that we sought to answer individually and as an institution over the last 3 decades. And what I'm going to share is not only my personal experiences, but also a lot of the research that has happened in our institution that has helped us understand a lot more about poisoning. So I've titled, are you able to see the slides? So I've titled this talk as Organophosphate Poisoning, My Journey Over 3 decades. Uh, these 3 decades have been of learning and discovery. And as I progress through my talk, you will understand how things have changed over the last 3 decades. And all these journeys starts with a very small step. And for many of you who are young, intensivists or physicians or researchers, take that first step to look at a topic where you want to spend a lifetime giving answers to the scientific community. So I'll start with a brief introduction. I put down the initial years as 1987 to 1991 when I was an intern and how we managed OP poisoning. The mid years, I put it as 1991 to 2000. As a postgraduate and as a young physician, what was the evidence that came out? And the latter years, from the year 2000 to present, what has happened? And I've just briefly dwell on where we are heading to in the future in terms of this particular disease. Now, organophosphorus poisoning is a very common cause of admission, and the WHO, it's a little old data, but reports about 18.2 acute pesticide exposures per 100,000 agricultural workers. There are about 3 million poisonings that happen a year. So it's not a small problem globally. And it's if you look at it contextually, this number is much, much larger than the corona pandemic at this point of time. So in India, it is an epidemic, and the Hindu reports that there is one farmer suicide every 30 minutes. So again, if you look at the number of deaths that are happening due to organophosphate poisoning, it's a huge number. There is this big five that we call, which contributes to so much of the suicides in the country, and it's Chhattisgarh, Maharashtra, Karnataka, Andhra Pradesh, and Madhya Pradesh that contribute to the major disease burden in the country. If you look at a cohort of patients present in the hospitals that do look after patients with poisoning, a significant proportion of admissions are due to organophosphorus poisoning. This is a study that was published from Andhra Pradesh in 2010. I'll start with the initial years, starting with my internship days. One of the first exposures to organophosphate poisonings was during my internship days, and we had limited understanding of the pathophysiology of organophosphate poisoning. Gastric lavage used to be done very vehemently and in a manner that was quite concerning in the emergency department. The large bore tubes were given for lavage, and often It was also done with an intention to say, will you do it again? This is what you'll go through it. And there was little emphasis on airway protection. It was a very small medical critical care at the point of time that when we were doing internship, it was only 5 beds, and only the severe poisoning was admitted and used to have intubated patients. I remember walking around with this Atropine, huge multi-dose vials, constantly administering Atropine, because in those days we were expected to keep the heart rate at about 150. The patient had to be agitated. We had to target very clear secretions. The axilla had to be dry, pupils had to be fixed and dilated, and bowel sounds should be absent. And this is how we managed opioid poisoning in those days when we did not understand so much about physiology. And during those days, I very clearly remember only about 50% of the patients used to survive severe poisoning. Moving on to the period between 91 to 2000, this was a year that there was a lot of focus on oximes, pralidoxime, particularly it was being used quite a bit. And there was some belief by my teacher and mentor, Professor A.M. Cherian, who said that oximes may actually harm. There were strong ethical issues to the study based on animal studies, because animal studies showed benefit. And when we applied to the Institutional Review Board and Ethics Committee for a placebo-controlled trial in humans, it was rejected on the basis that there is benefit in animals. How can you even do a placebo-controlled trial? So first randomized controlled trial was exploring high dose and low dose. And to our surprise, we found that the low dose Oxime actually did much better than the high dose. Subsequently, we embarked on 2 randomized trials, and that gave us a lot more insights on the role of oximes. I'll talk about this a bit later. And all these studies happened between early 90s to mid 2000. Now, if you look at globally, all the studies that have been published on oximes, where there is a control arm where they compared it with no oximes, there are 4 retrospective studies, 2 prospective studies which were non-randomized, 2 placebo-controlled trials from India, and 3 randomized controlled trials that explored different doses. And the mortality in the Oxime group in CMC was 30%. Now, when you pool all these studies into meta-analytic analysis, these are forest plots. You may be familiar with this. Now you have the central line, the vertical line, which is the line of null effect. If the studies, the point estimates fall to the right of the null, it means there is a potential harm. It is estimates beyond 0. If it falls on the left of the central line or vertical line, it means it is protective. So harmful on the right, harmful on the right, protective on the left. And if you look at all the studies, there is no study which shows there may be a potential benefit. In fact, if you look at the prospective studies, it appears that there may be some harm. But this meta-analysis is subject to some criticism because we are pooling retrospective studies and prospective studies in a pooled analysis. There was a lot of effort taken to adjust for these, but still it is hypothesis generating. If you look at ventilation again, the ventilation risk was higher if they were on high dose oximes. The need for ICU was higher. And this was published about 15 years back or 14 years back in the clinical experimental opinion in pharmacotherapy. Now, when we look at the 2001 to present, where have we reached? We have a better understanding of the mechanism of manifestations. We have a lot of knowledge on the determinants of toxicity and greater insight on management aspects. So let us look at the mechanisms of manifestations. Now, when we look at the manifestations in organophosphate poisoning, we can look at it in 3 ways. One is a receptor-based approach. The second is a time-based approach. The third is an organ-based approach. Let's look at this a bit more in detail. Now, when you look at the receptor-based approach, you're all aware that there is the adrenergic system and the cholinergic system. There are peripheral receptors, central receptors. There are muscarinic receptors and nicotinic receptors. So these are broadly the receptors on which the organophosphate compounds will act, basically on the cholinergic system. Now, if it acts on the central receptors, there are central receptors, both muscarinic and nicotinic receptors. and they are responsible for the central manifestations. So patient presenting with anxiety, restlessness, ataxia, convulsions, insomnia, dysarthria, tremors, all those are central manifestations based on the action of organophosphate compounds on these receptors in the brain. Next, we have the sludge symptoms, which are predominantly manifest because of its action on the muscarinic receptors. And the muscarinic receptors also, it's the M2 and the M3 receptors. And these cause the sludge symptoms, salivation, lacrimation, urination, defecation, gastric cramps, and emesis. On the other end, we have the neuromuscular symptoms and manifestations, which are due to the nicotinic effect on the N1 receptors, which is present in the motor and plate and skeletal muscle, and the increased heart rate and blood pressure response, which we sometimes paradoxically see in OP poisoning, is through the nicotinic receptors, that is the N2 receptors. Now, why should we bother about looking at a receptor-based implication? Because the choice of your anticholinergic, for example, is dependent on which receptor it works. We have broadly three types of anticholinergic drugs: atropine, glycopyrrolate, and scopolamine. And we know that atropine crosses the blood-brain barrier, and it does reverse some of the central nervous system effects, particularly the initial effects. It does counter some of the effects. Glycopyrrolate, on the other hand, does not cross the blood-brain barrier. And so when patients develop atropine toxicity, you can use glycopyrrolate as an alternative. Among the three drugs, scopolamine has the highest CNS penetration, and there are case reports where severe extrapyramidal symptoms due to OP poisoning has been reversed with the use of scopolamine. So certainly it's our understanding of the receptor level effect that has helped us recognize that atropine, glycopyrrolate, and scopolamine can be used for three different components of the manifestations of OP poisoning. Now, the second reason why we need to know something about receptors is what is the muscle relaxant that you will use if you have to intubate a patient. Now, we all know about choline apnea, particularly the anesthetists are very familiar with this entity. Now, when you have somebody who was taken as organophosphate compounds, acetylcholine is blocked, acetylcholine esterase is blocked. And we know that succinylcholine is detoxified by acetylcholine esterase or pseudocholine esterase. So they can have prolonged choline apnea. So the choice of muscle relaxant in an OP poisoning cannot be succinylcholine, but something like rocuronium or those class of drugs. And this is important to remember, again, based on a receptor-based mechanism. I will talk a little bit later about atropine refractoriness. We do see a subset of patients, despite giving very high doses of atropine, you will be going up from 10 milligrams to 20 milligrams to 30 milligrams per hour. And you find that their heart rate does not just budge. And this again is based on a receptor-based blockade. And this I'll actually talk about it when I talk about atropine. And it's also important to understand the pathophysiological basis of the manifestations, because in future, who knows, one of you may be able to identify or develop new drugs which are extremely specific to certain receptors. For example, you may be able to counteract the cardiac toxicity effects of bradycardia and hypotension with certain specific drugs which act on those receptors. The second is the time-based manifestations. Now we know some of the manifestations present very, very acutely within minutes to 24 hours. And these are the muscarinic, nicotinic, and central nervous manifestations. All three manifestations can occur. Now some manifestations are delayed, occur after 24 hours and up to a period of 2 weeks. And then we have late manifestations, which occurs beyond 2 weeks. And those include the type 3 paralysis, cerebellar manifestations, ocular or ENT manifestations, and chronic organophosphate-induced neuropsychiatric disorders. Now, many authors and many toxicologists prefer to club both these delayed and late manifestations together. But because they are pathophysiologically a little different, I prefer to actually separate them out as delayed manifestations and late manifestations. Now, if you want to put a timeline of how these manifestations occur, I'll present such a chart. So in the first 24 hours, the initial cholinergic phase happens. So patients have the sludge symptoms, they then have some muscle weakness, they have some central nervous system manifestations, agitation, restlessness, or drowsiness, seizures. That happens within the first 24 hours. They are the early manifestations. Now, there are case reports of patients who do not manifest any cholinergic symptom in the first 24 to 48 hours, but after 48 hours start having the first cholinergic manifestations. Now we know now, based on our understanding of pathophysiology, the oxons and the thiones, these are two different types of compounds, have to be converted in the liver to an active form, and that may be the reason why some of these symptoms may be delayed. We all are aware of the classical intermediate syndrome, which is neuromuscular weakness that occurs 48 hours usually to 96 hours after the onset of cholinergic symptoms. This was first described by Senanayake in 1987, and that is also a delayed manifestation. Now, there are situations where delayed onset of intermediate syndrome has been reported even at 114 hours. So it is not standard that they have to occur between 24 to 96 hours. It can be delayed as late as 5 days. More recently, we have, it's not really recent, about 12 years back, we described an entity called delayed onset encephalopathy or coma in a subset of patients. This occurs in about 15 or 20% of patients with severe poisoning. And what happens is, in these subset of patients, they're quite conscious and awake when they come. They're conscious up to 4th to 5th day. By the 5th day, they start becoming encephalopathic. Some of them drop their GCS quite significantly and stay with a low GCS. Some others actually drop their GCS down to 3T. And this is a subset, they behave exactly like brain death. They have no cough, no gag reflex, no spontaneous respirations, no response to painful stimuli, oculocephalic reflexes are all absent. So they behave typically like brain death. And there are several clinicians who said, oh, this patient is brain dead. Why can't we withdraw? When we looked at this cohort of patients, we did a lot of investigations, including CT brain, CSF studies. EEG showed actually they were not dead, but there was biased hemispheric slowing. And these people, given time, after 2 or 3 or 4 days, slowly recover and regain consciousness and become normal and get discharged. Now, this is a very small subset of patients, and that's a very, very simple bedside test that you can do to say this is a mimic of brain death. This is not true brain death. And the simple bedside sign is pupils. In delayed organophosphate coma, the pupils are small and non-reactive. In true brain death, it's dilated and fixed. Then there is also the delayed onset extrapyramidal symptoms. We have also characterized this in our own institution in a fairly large number of patients. And this again typically starts between 5 to 7 days. The symptoms peak by about 2 weeks, and they settle down spontaneously by the 3rd week. And you can treat this with some anti-Parkinson drugs. Now, moving on from that manifestation, so what determines toxicity? Now, we now know that although organophosphate compounds is considered as one entity, there are several factors which determine toxicity of the individual compounds. The first is the WHO class. The second is the chemical structure. Third is whether they have mixed it with other poisons. Fourth is the amount that they've ingested. Fifth is whether it's fat soluble or water soluble. There is a lot of interest in this now. And what is the lag time to seek medical help? I'm going to focus on the first 3 because we have a lot more that we have understood about these 3 in the last 10 to 12 years. The first is we looked at a cohort of patients who were admitted in our institution with OP poisoning, and we classified them based on the WHO class. Now we must remember that this WHO class or the WHO hazard class is derived from animal toxicity studies based on LD50, so lethality amongst animals. And we found that when we classified them based on that classification as class 1, class 2, and class 3, we found that the highest mortality was in class 1 compounds. It was lower in class 2, and none of the patients who had ingested class 3 compounds died. This is very interesting because it has a lot of public health implications on what are the compounds that you need to regulate or legislate. I must say that, for example, Kerala took the leadership in banning a very, very toxic compound, which is endosulfan, an organophosphorus. With a lot of push, they finally got it banned. And this is what we need for organophosphate also. We know for sure with evidence in humans that the biggest culprits are WHO class 1. And among the class 1, it is monocrotophos and parathion that has the highest lethality. Monocrotophos is more than 20% die, severe poison. And so it is up to us to negotiate, lobby with the regulators and say, can we ban these? So that at least patients can come to hospital and have a chance of survival. The second is we looked at whether the biochemical characteristics or the structure of the organophosphate compounds has anything to do with outcomes. So we looked at, again, the same cohort of 396 patients, and we classified them as dimethyl compounds, diethyl compounds, and third group was unknown. We actually didn't have too many of the alkyl compounds. That is the third group of organophosphate compounds which we see in practice. But between the dimethyl and diethyl, we looked at several characteristics. And what we observed was dimethyl compounds fared worse than diethyl compounds, and the oxons were worse than thiones. I'm not going to elaborate more on this, but this is just to tell you that there are several characteristics of these compounds that actually influence outcome in human poisoning. Now, the other thing that we found recently was that a lot of farmers are using a combination of OP and pyrethroid for better protection for their crops. And we looked at a cohort of patients who had come with mixed poisoning and compared them with chlorpyrifos alone, which is an organophosphate compound. And we also compared the mixed with cypermethrin, which is a pyrethroid. Now, the mixed compound contains a combination of chlorpyrifos and cypermethrin. What we found was when patients ingested this combination of cypermethrin and chlorpyrifos, the mortality was 13%. If they took only chlorpyrifos, all survived. If they took only cypermethrin, all survived. Now, we know now that there is a reason why this potentiation of effect happens, because these two compounds interact with each other and increase the toxicity of the compounds. The higher mortality is also because there is a higher concentration of chlorpyrifos that is used in the mixture when compared to chlorpyrifos, which is sold separately. We move on to management. Now, in management, I need to look at 4 dimensions. Can we do anything to reduce the absorption? So that's the first component. Second is, once the compound is absorbed, can you do something to the circulating organophosphate? Can you bind it? Or can you counteract some of the effects? And the effects are on the heart, on the muscle, on oxidative stress, on the lungs, or on the respiratory, on the central nervous system. So the third component of management is, can we counteract? So first component is, can we reduce absorption? Second component, whether we can modulate effects with certain drugs, and some of the drugs are coming up. Magnesium, N-acetylcysteine, adenosine, atropine. Or can we neutralize the toxin using oximes or using bioscavengers like albumin or fresh frozen plasma? or purified butyryl fluorinesterase. And finally, the fourth component of management is can we enhance the elimination of these drugs, either through hemoperfusion or alkalinization, or another process which is called bioremediation, which is by using drugs called hydrolases, which hydrolyzes the organophosphate. I will go through only some of the salient ones. Can we reduce absorption? There are two components to reducing absorption. We can decontaminate the skin and we can do gut decontamination. And this is done routinely where we give a wash to the patients with soap and water so that we reduce the skin contamination. The gut contamination, there are several processes that we can employ. Post-emesis can be tried if the patient is awake, gastric lavage, activated charcoal, and sorbitol. Now we know that gastric lavage is useless if it is delayed. And there are lots of studies. We have recently completed a study where we found that what is recovered from gastric lavage is extremely small if it has crossed 2 hours. And although we passionately do this in casualty or the emergency department, we are not sure whether it has any benefit. In fact, if you look at the recommendations of the toxicology groups, they say that gastric lavage should not be employed routinely, if ever, in the management of poison patients. And that is because there are a whole lot of complications that can occur if it is not properly done and if the airway is not protected. Now, there is a lot of interest on activated charcoal, and this is the largest study that was published from Sri Lanka in the Lancet. They looked at two types of poisoning, both plant and pesticide, and there are 3 groups: high dose charcoal, single dose charcoal, and placebo. And they found that activated charcoal did not have any effect on outcomes in these cohort of patients. So now moving on from absorption to neutralization, and there are 2 modalities of treatment that we can look at: Oximes. Now I just want to focus on some of the newer studies that have created a little bit of controversy. This was a study that was published from Pune, which looked at a cohort of patients who came extremely early, within 2 hours. And they used very high dose oximes. They used 50 grams of oximes in 48 hours. Remember, in the studies that we presented earlier, it was 12 grams, maximum of 12 grams. So these people used 4 times the dose because they believed that the dose that we used was not sufficient. They found that there was a reduction in death rate if they used it in patients who presented extremely early. Now, one of the drawbacks of that study was if the patient came very late or if the patient was extremely sick, they transferred them to the government hospital. So there was a bit of selection bias in their cohort. Now, because of the study, the Sri Lankan group decided they will do a very large study on oximes. They have done the largest randomized controlled trial comparing pralitoxin with saline. What did they find? They found that overall there was a trend to harm if they used oxime as opposed to placebo. And these are the graphs that came out in that study. They also used very high dose. So how do we summarize the results of the oximes? Remember, I presented the meta-analysis earlier, which suggested null effect or potential harm. The largest oxime study tended to harm, but the Pune study showed a reduction in mortality if used in high dose. Now, how do you take this forward? Do you use or you don't use? Based on the evidence, if at all you want to use, you can use it in patients who present extremely early, less than 2 hours. But if they present late, there is a huge potential for harm. And there are several reasons why it may cause harm. You can go through one of our review articles as to what are the mechanisms that cause harm if you use it late. Second is called Bioscavenger therapy. So what people said is, why can't we use cholinesterase as an anti-OP agent? So you have free toxin that is floating around in the blood. Before it gets bound to the receptors, why don't you give acetylcholine, free cholinesterase, and bind to them? So there are different ways of doing it. We can use fresh frozen plasma, which is very rich in pseudocholinesterase. We can use albumin, which also binds to OP, free OP. And we did a randomized trial comparing fresh frozen plasma, albumin, and saline, and found that there was no difference in outcomes despite the pseudocholinesterase levels improving with fresh frozen plasma. So biochemically, there is an improvement in pseudocholinesterase levels, but clinically, there is no change in outcomes. Subsequently, there was a study from Turkey and another study from Malaysia, and both these studies also did not show a benefit with fresh frozen plasma. So bioscavenger therapy also seems to be out for the moment. The next dimension is, now that you can't bind, there's no merit in reducing the absorption, can you at least modulate the effects? And there are several agents that have been used, and I've just listed all the agents that have been used. I want to take some time to focus on atropine, because that is a drug that has to be used effectively if you need to have good outcomes. There are a few questions that we ask about atropine. What should be the target? How do you titrate the dose? Do you give bolus or do you give infusions? What are the adverse reactions to atropine and how do you deal with it? And what is this atropine refractoriness and how do you treat this? Now, there are multiple regimens that are described, and the dose ranges from 1 to 5 milligram. The dose interval ranges from 2 to 30 milligrams. And this is what is recommended by the Sri Lankan group as the endpoints for atropine therapy. Clear chest, heart rate more than 80, pupils no longer pinpoint, dry axillate, and systolic blood pressure more than 80. We believe that some of these criteria are not optimal. So we say, on day one, when there is a potential for enterohepatic circulation of the drug, your monitoring may not be optimal. You need a little more buffer in the heart rate. So on day one, we target a heart rate of around 100. Day two, we target a heart rate of 90. From day three onwards, we target only a heart rate of 80. The second is, we also feel that a systolic blood pressure of more than 80 is not sufficient. There can be significant hypoperfusion at these lower systolic blood pressures. So we believe that we should target a systolic blood pressure of more than 90. That is the definition that we generally follow for sure. Now, we also feel that all these targets are not mandatory. There are only 3 things that can kill a patient who has come with opioid poisoning. They can drown in their secretions and die. They can die of severe bradycardia and then they can go into a tossage, or they can go into severe hypotension and shock and die. So these 3 are the mandatory targets that we should target. Absolutely essential. So atropinization should target these 3. Clear lung fields, heart rate more than 100, decreasing over the next 3 days, and systolic blood pressure more than 90. The other 2 targets I would put down as desirable. You don't need to have the pupils blown and fixed and dilated. You don't need to have absent bowel zones. This is something we were taught when we were interns. All you need is a pupil which is with cushion and bowel zones just. So this is something that has changed over the last 10-15 years. Now, what is the basis? Very high targets are detrimental. If you target very high heart rates, they're delirious, agitated, anxious, and it makes management very difficult. Too low also, as I said, it's a problem. They can, too low a heart rate, they can have malignant arrhythmias, and as I said earlier, they can drown in their own secretions. So you may ask me, how do you do it in practice? You can start with 1.8 milligrams of atropine, that is 3 vials, 3 milligram IV stat, or 2 to 4 milligrams if you have multi-dose vials, which comes in 1 milligram per ml per ml vials, and double the dose every 5 minutes till mandatory targets are met. Now, there are enough studies which have shown that doubling of dose versus ad hoc, you use lower dose if you titrating it, and your atropine toxicity is also less if you titrate it. So you give a dose, say 1 milligram no effect in 3 to 5 minutes, double it to 2 milligrams, no effect in 2 to 5 minutes, double it to 4 milligrams, 8 milligrams. And what studies have shown is you need to use only about 20 to 25 milligrams to get atropinization. Then we use Bolus or Atropine. It's only one open label randomized trial which is compared, and they found that infusions are slightly better than boluses. Of course, you need infusion pumps and things like that, so that has to be offset by the need and the availability. Now, what are the adverse reactions? There can be toxic and allergic reactions based on because of sensitivity to atropine, and these are quite rare. But tachycardia, tachypnea, elevated body temperature, and CNS stimulation is not uncommon. And if they occur, then we may need to switch over to glycopyrrolate, use small dose of benzodiazepine, and in severe cases, you may use haloperidol. But remember, in patients with OP poisoning, it increases the risk of neuroleptic malignant syndrome. Now, I talked about atropine refractoriness. Now, in some patients, a small subset of patients, we have seen this particularly with monocrotophos or parathion. You keep increasing the dose of atropine, the heart rate doesn't budge. It stays below 70. And there is a concern that very high dose atropine causes other side effects and toxicity. There are some patients we have used even up to 1,000 milligrams of atropine a day and not being able to reach a heart rate target of 90 to 100. So we did a study looking at what is atropine refractoriness if somebody needs more than 30 milligrams of atropine per hour for at least 3 hours, or a cumulative dose of 100 milligrams over 6 hours. We defined them as atropine refractory. And we looked at this cohort of 157 patients, and we found that patients who were atropine refractory were a bit older, and they tended to stay longer in hospital and had a longer duration of ventilation. Mortality was not significantly different, but this probably suggests that they have much more severe toxicity than the non-refractory group. If you look at the graph there, the graphs which are very low are the below 100 are the ones where they were quite atropine refractory in the lowest point. And then when we started very low dose adrenaline, 1 to 2 micrograms per minute, the heart rate came up and the atropine requirement started coming down. So the treatment for atropine refractoriness, if it persists for 6 to 8 hours, infuse a very tiny dose of adrenaline as an infusion. The atropine requirements will come down, your heart rate will come up, your blood pressure will come up, and hemodynamically the patient will do much better. There are several other adjuvants that have been tried. Magnesium is something that has shown some promise in terms of lower hospitalization and mortality. But there are lots of flaws in the design, and this has never been taken up in a larger trial. Diazepam is also used mainly for seizures, and there are 2 studies with the charcoal chemoperfusion, one suggesting some benefit and one suggesting there's no benefit. And again, the key factor seems to be how early do you start your treatment. There are some other observations that I would like to share. You will find that the patient is ready for extubation. They have good vital capacity, the muscle power is improved, and you've done an entire screening, your metabolic parameters are normal, the hemodynamics are normal, conscious, they're ready for extubation. They pass the cuff lead, you extubate them, they fail extubation. And there are 2 reasons why they could fail extubation. One is there a constant release of organophosphate into the circulation? I talked about, remember earlier, fat soluble organophosphate compounds. So there are some organophosphate compounds which are very lipophilic. And there are studies which have shown that the fat concentration of OP is 20 times higher than the serum concentration. And so these fat can be, the organophosphate compound can be sequestered into the fat, and it can slowly release over time. And that could possibly explain why they may fail. But we also have done another study which is not yet published, where we found that some of these patients have vocal cord dysfunction. So they fail not because of neuromuscular weakness, which is generalized, but specifically vocal cord dysfunction related to organophosphate poisoning. So how do you treat it? You may have to reintubate and do a tracheostomy, wait for the vocal cord dysfunction to settle, and they will get better and get well. So what is the future? I think we need to address from a country perspective 3 dimensions. We need to reduce suicides. We need to reduce the toxicity of the drugs which are used and manage better. And if you do all these 3, you will save lives. And we focused a lot on managing the patients better. How do we reduce suicide burden? It needs a whole lot of social reform, economic development, educational empowerment. In terms of toxin potency, as I mentioned earlier, we need to ban the highly toxic pesticides. Sri Lanka has banned all the class 1 compounds. And we know that dimethyl compounds are worse. WHO class 1s are worse. Monocrotophos is bad. Parathine is bad. Borate is bad. So can we get some legislation to ban these compounds like we banned endosulfan? Replace them with less toxic pesticides. Today, we are just writing up an article on pyrethroid poisoning. We have 250 patients over 5 years. No mortality. They come with some symptoms. So can we replace these toxic pesticides with less toxic pesticides? Second is safe storage. I think there is so much of merit in doing this. The Sri Lankan group has done this very effectively. It is kept under lock and key so that there is no easy access to people who want to take it one from the shelf and use it. The third is, I think we need to look at diluting the pesticide. We get 30% monocrotophos or 50% chlorpyrifos, very concentrated solutions. So why do they sell it concentrated? Because packaging cost, transport cost is high. So if we can encourage industry to sell dilute pesticide, you will have to drink 2 liters to get the same effect rather than a 30 ml bottle. Now this needs a whole lot of change in practice, and we cannot do it on our own. I can draw the parallel to the UK experience, where they used to see a lot of patients dying with paracetamol toxicity because of the sale of over-the-counter paracetamol. They did a very simple thing. They blister packed all the paracetamol and double sealed it. Now, in an impulsive act, you first have to remove the blister pack and the seal, and then open it, and one by one you'll have to take the paracetamol. Previously it used to be in a box, so you can take 10 or 20 and take. So we need to do something innovative to reduce the potency or the intensity of the poison. Now, what are the new treatments that may be promising? Whole bowel irrigation is something that people have tried that may show some promise. In terms of neutralizing toxins, we probably need to look at newer oximes. So very targeted, and we also need to look at the timing. There are people who are trying to develop purified butyryl cholinesterase. Whether that will be beneficial, we don't know. Lipid synthesis, very interesting compound, concept that has been used in tricyclic antidepressants. And there are some animal studies which suggest that it may be beneficial. That's another treatment that we can think of. In terms of modulating effects, remember I talked about receptor-specific anticholinergics. I think we need to look at such drugs, develop such drugs. And of course, clonidine and N-acetylcysteine have also been tried. And of course, early hemoperfusion and bioremediation are far away in terms of treatments. We can also think of combination therapies. But what makes the difference? I think better supportive care makes a big difference to the outcome. In the pre-ventilation era, or as I said, when I was doing internship, was 50% mortality. If you look at our own data between 1999 and 2005, mortality of severe poisoning is 15%. Subsequent mortality is less than 10%. Currently, if a patient with opioid poisoning dies, we ask them how come he died. So it is good supportive care is what makes the difference. So I want to conclude by saying we have come a long way. We have a much better understanding of mechanism of toxicity, and outcomes have improved with better understanding, good supportive treatment, and intensive care. And I do believe the future is hopeful. Thank you.
Sir, can you hear me, sir?
Yes.
I know he's having some connection issues, internet connectivity issues, sir. So there were some queries in our chat box. Some people wanted to know clarification regarding the repeat doses of atropine and oximes.
So what I would suggest is start with 1 or 2 milligrams as a bolus. Start of the infusion along with it, say 1 to 2 milligrams per hour. You need to have a target heart rate of about 100, systolic blood pressure of 90, and clear lung fills. If you haven't achieved in 3 to 5 minutes, double the bolus dose to 2 milligrams. Still not achieved, double the dose to 4 milligrams. 8. Till those 3 mandatory targets are reached. Once that mandatory target is reached, then you titrate the atropine infusion. You may start with 3 or 4 milligrams per hour. And if the heart rate is sort of tending to drop, give a small bolus and increase the dose. And if the heart rate is maintained at 100 on day 1, day 2, you are targeting only 90. So when you're targeting 90, you start reducing the dose. By day 3 or 4, your atropine requirement should not be more than 1 milligram per hour. By 4th or 5th day, you should be able to stop.
Okay. And there was again query regarding duration of paradoxime, if at all used.
I must say I'm a non-believer of paradoxime because we have done so many studies and we have seen a lot of harm. I'll tell you what is one of the problems. Now, when the organophosphate compound binds to the acetylcholine receptors, the binding is permanent. Now, you can give an oxime to lift the organophosphate off the acetylcholine esterase, provided it's given early. If you give it late, what happens is that it undergoes a process called phosphorylation. When the phosphorylation occurs, this complex becomes what we call aged. It's called phosphoryl oxime. Now, this phosphoryl oxime is more toxic than the organophosphate compound. So once it's aged, it cannot be reversed. So now if you keep giving more and more oxime, you will form more and more phosphoryl oximes and you'll potentiate the toxicity. So that is the problem. So the window period they say is in diethyl compounds, you can give it probably up to even 12 hours. But in dimethyl, it has to be within 2 hours. And that's probably the reason why the Pune group showed a mortality benefit. So if it's within 2 hours, you're supposed to use technically half a gram of paradoxime per hour as an infusion. That's the minimum recommended dose. And you may be spending 50,000 on paradoxime, whereas your whole stay without paradoxime may cost you cheaper.
There was a query regarding how to distinguish extrapyramidal symptoms from those due to atropine toxicity.
Okay, so they have very typical extrapyramidal manifestations: rigidity, coagulate rigidity, tremors. So what I would suggest is we have published a paper. Go through that paper. They're very characteristic. Your atropine toxicity happens in the first 2 or 3 days, and it's agitation, restlessness, confusion. All the anticholinergic signs, mad as a hatter, and high temperatures. That's very different from the typical extrapyramidal manifestations which happen after 10 days. It's between 7 and 14 days.
I think some of the queries are from those who have joined late. So for your information, we have done YouTube live streaming of this lecture, which will be available from the YouTube channel, in our YouTube channel, Webinar Campus. So you can run through the lecture all over again. So those who have joined a little late, because we can't keep on repeating whatever we have mentioned. There were some interesting questions also, like can we differentiate between organophosphorus poisoning coma mimicking brain death if patient is on atropine, which may dilate pupils?
Let me talk about a few mimics of brain death. I think one of the common mimics is great bite. And we have had elderly patients who are presented like a brainstem stroke. We've almost written them off and they wake up. And OP coma is the other mimic. Now, interestingly, the OP coma occurs towards the end of the first week. By the time they are generally off atropine, because it's not a cholinergic manifestation. They may have a little more secretions. I may need a very small dose of atropine, but not enough to dilate your pupils like that. They still have small pupils. This is so typical. You must see it to believe it. Absolutely like brain dead. You look at the pupil, it's small. If it's not a typical fixed and dilated pupils, wait. If it's fixed and dilated, do an EEG. If there's electrical activity, wait. You don't even need to do anything else. That's a simple way of approaching it. They will wake up in 3-4 days.
Okay. In query on, is there any use of lipid emulsions?
As I said, there is some animal work that have suggested some benefit, but it needs some trials in humans. What I would suggest is it's very important to find out what compound they took. And in our diethyl paper, which is published in Clinical Toxicology, we've actually listed the lipid solubility of each of these compounds. So if it's a very lipid soluble drug, there's no harm in trying, but there's no evidence in humans. You could use it, may not harm.
Okay, fine. Any role for hemodialysis?
Hemoperfusion, there's probably some role if presenting very early. But again, even the best centers in the world do not offer hemoperfusion because of costs involved. So if they present very early, there may be a role, but the evidence is not convincing.
We have gone through.
Sir, can you hear me now? Sir, this magnesium and N-acetylcysteine, can you explain at what point we will use that?
So what we do in our unit is titrate magnesium to therapeutic levels. So the evidence based on studies are quite weak. There may be a potential role, so we just ensure that magnesium levels are optimal. NAC, again, we are not sure. There is a lot of free radical generation in OP poisoning. We recently completed a study that has looked at infections in OP poisoning, and we find that they have a much higher risk of infection compared to any other poison, even though the mortality is half that of other poisons. So there is probably some role of, there may be a role, we don't know.
And what about this absorption therapy, sir? Because nowadays, so many companies are coming up with so many membranes saying that if you use it very early in OP poisoning, you can even prevent the patient going for other complications, even like the muscle weakness, intermediate syndrome, all those things. So
best is to do a study, otherwise we will never know. Anecdotal reports won't help.
There is one company called Delvin, they approached me. So I also told them same thing. So they wanted to do the study with the patient cost. I told that is not possible. If you want to do a study, you provide the cartridge free of cost, like at least the initial 25 patients we'll see and we will do and see whether it's really going to benefit. And sir, one more this intermediate syndrome, what is the present concept regarding the pathophysiology? Because we have heard so many other things like it is getting absorbed to the fat, get later release, and so many other reactivations, so many things. So what is the present concept regarding intermediate syndrome?
So basically there is phosphorylation of the receptors. So the complex gets phosphorylated and it has to be regenerated. Till it's regenerated, it's not you're not going to recover from your weakness. So that's a broad. Some also talk about hyperstimulation initially, and then there is a complete blockade. So that is why the type 1 paralysis is hyperstimulation of the nicotinic motor enplate receptors. And in the second phase, it's hypostimulation, blockade. Now, this concept about reabsorption is probably true because we have found that also in OP coma, it occurs late, probably because it's absorbed into the circulation into the lipid stores, and then it is released slowly, and then it saturates the neuronal receptors.
So the same way, like you were talking about succinylcholine, again, the prolonged apnea, all those things. Like in a OP poisoning, whenever we are intubate, we are not expecting the patient to get extubated in another 2 to 3 days. Probably we late, maybe for longer time. So in that scenario, do you think this scoline apnea is really going to be harmful in an ICU setting?
Probably not. Probably they may not have a clinical significance. There are a few case reports where they've suggested that they needed intubation for longer than they felt it was necessary. Again, we were hoping to do a trial, but we dropped it because it's going to be very difficult to show a difference, as you said. So what if they are going to be apneic for a longer time? Anyhow, they need intubation for 3-4 days.
And so the same way regarding the use of the atropine versus glycopyrrolate. Based on the chemical nature, can we assume that these are the compound going to have more CNS effect, and you should not use glycopyrrolate in a particular group of OP poisoning?
See, there is some evidence that giving atropine is better because it goes through the blood-brain barrier and counters some of the CNS effects. And I would use glycopyrrolate only if there's significant CNS toxicity without the heart rate coming up. It's more expensive, so I wouldn't use it routinely. Offhand, I don't know the dose of glycopyrrolate. You can look at the dose from the books or from anesthetists. Anup can tell you.
Usually what we do, sir, like especially if the patient is not having CNS symptoms, especially when we are shifting the patient out of ICU, this glycopyrrolate, we can give it as an intermittent bolus dosages. And again, these delirious effects will be less. So that is the situation where we usually go into a switch over therapy like that. Otherwise, in ICU, again, glycopyrrolate, like I have not used much.
Okay.
And sir, other thing is regarding this atropine. Again, they are report saying that you can use and so, do you think like is there any method of like preventing or treating that?
I couldn't really hear the question properly.
Sir, the atropine psychosis. So, like, can we use physostigmine to reverse the effects of like atropine in the CNS?
I wouldn't try any of those. A little bit of diazepam. If it's very severe, we use haloperidol because you don't want the OP toxicity to take over.
Yes, sir. Then, Sunny sir, questions?
And some of the questions actually are from people who have joined late. So I have mentioned that we can go to the YouTube channel and get the full lecture again.
So somebody has asked, how is cholinesterase level helpful with regards to treatment? Now, if you have the facility to do red cell cholinesterase, it correlates with neuronal cholinesterase. Pseudocholinesterase typically doesn't correlate with toxicity, except very low dose. There is a recent study from Sri Lanka which suggests that extremely low cholinesterase, which is persistently low, means that the patient has been overdosed too much. But red cell cholinesterase, certainly there is some correlation between severity of poisoning and the level. And somebody wants me to elaborate on ABCMN. It's a mnemonic that I use. airway, breathing, circulation, metabolic, and neurologic. So 5 criteria have to be fulfilled. To ensure that the airway is likely to be patent, the breathing is adequate, circulation is stable, there are monometabolic determinants like hypophosphatemia or hypokalemia, and neurologically, it should be okay. Have an FVC of at least 15 ml per kg. So that is the ABC and then.
Sir,
Sorry?
many persons were asking about gastric lavage, sir, because like as you are well aware, like majority of the centers still practices this gastric lavage for all the like poisoning. May not be the way you have shown in the initial UG days. That people have changed, but still putting ice tube or big bore ice tubes and again giving a saline bolus is a routine practice everywhere. And again, even the physicians, majority of the physicians think that if you are not doing that, it is something like a criminal offense what we are doing.
See, that is a problem. So that is a problem that people still believe it works. So, in fact, there is, I think, let's wait for our study to come out. We have shown that the fraction that you take away from on a gastric lavage is so minuscule that the risk outweighs the benefit. So if they come within 6 hours, we still do, but beyond 6 hours, there's no benefit at all. Technically, it should be less than 2 hours. Somebody has asked when to. Sorry.
You do only your ice tube, no, sir? Now the
yes, only ice tube. We don't do big dose. Somebody wants to know when to start feeding. We start feeding after 24 hours. Even if the bowel sounds are not well heard. There is a study that we have published again in clinical toxicology where we have shown that feeding is well tolerated and doesn't harm.
So some patients will go for a severe ileus, sir. That is the problem. Like last time I had one patient who went into severe ileus, was not tolerating feeds for many days, and we have to start him on like parenteral nutrition. But majority of the time, as you've told, like just modifying the enteral feeds and everything, they'll tolerate.
So the idea is to start very low, 20 ml per hour. And depending on tolerance, look at gastric residual volume, you can increase. By 5th day, you should be able to get to, it has to be a little slower. You may reach target nutrition only by 5th or 6th day. So that's the way to go.
Again, some patients will definitely go into the persistent weakness like maybe because of ICU weakness also getting along with the OP poisoning. I still have a patient who was there on ventilator, then on tracheostomy, then on BiPAP through tracheostomy for almost 2 months. So now he is completely recovered, but he's having persistent weakness in the lower limb. Still, he's not able to walk even. Only one patient.
So that is, we do see it occasionally, but some of them may develop a type 3 organophosphate induced neuropathy also. They are distal weakness. So if it's distal, think of OP related. If it's still generalized, proximal more than distal, you think of critical illness polyneuropathy. If it persists for more than, say, 2 weeks.
Now, unfortunately, this fellow went into Ayurvedic treatment, had massage, then developed contracture, all those complications. Even I sent him to Vellore for rehabilitation. They did contracture release, all those things. But still, is the lower limb power is not regained. And those are persistent bradycardia also what is approach in between. I lost you, sir. Even I had one last patient, even the way you were talking, how much ever you titrate atropine, you may not get a control on the heart rate. Like they may be maintaining somewhere around 60 plus, but not severe bradycardia, but the target you may not be able to achieve.
So once you reach 30 milligrams of atropine per hour for at least 3 hours, 30, or a cumulative dose of 100 milligrams over 6 hours, you start a very tiny dose of adrenaline as infusion, 1 to 2 mics. It will bring up the heart rate beautifully. There is a reason why it happens. Now you have both the sympathetic and the parasympathetic chain. And the neurotransmitter at the sympathetic preganglionic is also acetylcholine. So if that gets blocked significantly, your norepinephrine release at the postganglionic neurons is reduced. And so if you supplement externally with a tiny dose of adrenaline, the heart rate picks up beautifully. We have just finished the study. We are going to publish it soon.
But I tried with dopamine also in few patients, and it was also working very nicely. Low dose dopamine, just like that HA protocol. No?
Yeah, dopamine or adrenaline. Adrenaline is better because it's less toxic than dopamine.
And, anything else, sir?
Unless anyone has any questions. Somebody has asked for prophylactic antibiotics, no role. Anticonvulsants, you can come off them quickly after the acute episode is over, maybe 2 or 3 months, and then come off, unless they have hypoxic injury to the brain. Otherwise, you don't need anticonvulsants.
One person was asking, sir, when you have to suspect the delayed OP-induced neuropathy.
Usually, the persistent weakness beyond 2 months is when we suspect, and it has to be distal weakness. It is not very commonly seen with acute poisoning. It's seen more with chronic exposures. I'm yet to see a OP-induced delayed neuropathy. The typical one, where it's distal weakness, more motor than sensory. Some may have a little bit of sensory involvement, is what is described, but it's very, very unusual.
Many people have asked about how to taper stop atropine, sir, once we are stabilized with atropine.
So, as I was telling earlier, as the heart rate is maintained, you keep reducing the atropine dose every 4 to 6 hours. And you just maintain a target of 100 on day 1, 90 on day 2, 80 on day 3. And then every 4 to 6 hours from day 3, you can start tapering. As the heart rate drops too much, go up on the atropine. But by day 3, we find most of them come off a significant amount of atropine. We need half of 1 milligram per hour.
And again, another question is regarding the one which I've asked before, the clonidine, where you have to consider. It's only autonomic instability or any other reason?
Clonidine, actually, the Sri Lankan group tried a small cohort in animals, didn't really help, so they've given up. So I wouldn't suggest trying clonidine. Magnesium can be used.
But some group of patients we can see severe autonomic instability also.
You can try some magnesium in
that case. I think, sir, we have covered almost all the topics. So, thank you so much, sir, for that excellent lecture, and again, your beautiful slides as well. Will you mind sharing that in PDF form, which we can share with the trainees?
Sure, I can do that. I'll send it to you.
Okay.
Okay.
Thank you, sir. Thank you so much.
Thank you.
And thank you, friends. Again, tomorrow we have again one more very important topic, especially for critical care trainees. Dr. Jose Chaco will be joining us with 2 modules on renal replacement therapy. So tomorrow is module 1, where he will be talking on the basics and again the CRRT. So please attend tomorrow's session. And on Friday, we will be having Dr. Amarja talking on respiratory physiology. So probably the St. John's Bangalore, they will be continuing with the basic physiology topics related to critical care. As you are all well aware, to learn medicine, critical care, and anesthesiology, you should have a proper physiology background. So definitely we'll try to cover the physiology topics. The same way, the pharmacology topics are also very, very important. So as I've told in the initial days, we are trying to discuss the basic, the drugs what we are using, and the pharmacology. Along with that, the antibiotics, the basics, we'll start probably in another 2 weeks' time. Maybe one day we will dedicate to antibiotics.
So we will try to finish that module as well. Sunny sir, you want to add anything?
Yeah, fine.
So thank you, Peter sir.
Yes.
Thank you for that excellent
Yes.
session. Thank you, dear friends. And we'll be back tomorrow. We will be having case discussions as well. So please read and come. The renal replacement therapy, the conviction, all those diffusion conviction, the modalities, all those things. At least read the basics from any of the basic critical care books or the dialysis books. Then you please attend. And again, the critical care trainees, if you are attending, please read about CRRT, other hybrid therapies, different modalities of CRRT, how to prescribe all those things. So once you read and come, it will be very easy for you to understand. Okay. So if you have any doubts regarding what topic to read, everything, you can contact me personally, where I can give you more suggestions on that. But that's a very, very important topic. Regarding the book, the questions, like either you can go with the Paul Marino has given the basic concepts or the host manual, or you can go with any other critical care textbooks. And again, there is a like renal dialysis one book itself. If I have the PDF of that, I'll try to share it in the Telegram group, but I have not read that very recently. I have that book. I'll put the PDF of the cover photo of that book. So if you can read that, it's very nice. I think it is the term is dialysis itself. Like all critical care trainees and used to read that book. Okay, so any other doubt if you have, you can talk. Or some participants are raising the hand. If you want to, sir, can you just yeah. Naresh Khanna, you want to talk something? Sir, can you just ask him what you want? I do not have the access now. Naresh, you want to ask something? Naresh, please unmute. One more person has. Okay. So I think they have accidentally raised the hand. So thank you so much and good night. So thank you, Peter sir, once again for this excellent talk. So next week also you'll be joining us with the plant poison, especially in South India. That's a very, very important topic on the plant poisoning. So you should know how to identify and how to treat that. So thank you so much and good night.